Um, Please let me introduce my second speaker, Dr. Gloria Rodrigues-Vega. She's from the beautiful Caribbean island, Puerto Rico, and she's an internal medicine, critical care, and neurocritical care specialist, graduated with honor from Cornell University. She finished her residency at the VA Caribbean Healthcare System and afterwards completed her fellowship at Brown University. She is currently the chief of the Department of Critical Care Medicine in San Pablo Cagos Private Hospital. She is currently involved in numerous national and international societies and has publications in peer-reviewed journals and co-editor of the book Critical Care Administration, a Comprehensive Clinical Guide. Dr. Gloria will talk to us about 10 common mistakes in the ICU. Please welcome Dr. Gloria.
Thank you, Dr. Alaa, for that kind introduction. I also want to thank Dr. Saad for creating this forum so that way we can share our knowledge with you and also the attendees share your knowledge with us. I think this is one of the good things the pandemic has brought about, that the barriers across the world make these types of interactions possible. I also want to thank Dr. Ahmed for making my job a little bit easier by emphasizing the role of communication and the role of teamwork when taking care of patients. You've also made it harder because your lecture was excellent. And
oh, thank you.
I wish we can have you back. And if the attendees agree with me, please like in your mega Facebook platform. That way we can have him back. I have nothing to disclose in terms of conflict of interest. And I want to start by sharing this video. I was on duty a couple of weeks ago, and I was presented a case with an ischemic stroke. I was about to have lunch, and I said, let me check the CT scan before having this patient come up to the ICU. And as you could have seen, this patient did not have an ischemic stroke. This patient had an extensive subarachnoid hemorrhage with acute hydrocephalus. So obviously, lunch was not in the schedule, and I had to call the neurosurgeon immediately and correct the diagnosis and treatment plan for this patient. So as a matter of introduction, we all know this book has been published since almost 21 years now. To err is human. And medical errors are common, not only in the ICU, but in the field of medicine. They occur 44,000 to 100,000 a year. And if we translate that, it means that 100 patients die from care in the USA. This is data that we brought about from the Committee on Safety from the legislator in the United States. There's also adverse drug events. They occur to a rate of 2 per 7 per admission, and that translates to 2 errors per day in the ICU. And less than half of them, for letting me know, and it was in the first one. So medication errors are very common in the ICU. Less than 50% of the therapeutics are made in the right way. So this is something that is very alarming, and it's not only related to the United States, it's also related to other countries. There's even medical errors related to the ICU in the Bena Hospital in Egypt. They are still happening. This data was before in the 2016, but new data from Yale and this one from Egypt 2020. So it's still something that is very common. So how do we relate these numbers to other things that we know? We had mentioned that errors occur, 100 patients a day are dying from them, and that they could occur to 50,000 to 100,000 per year. So when we bring that when we have less than 1 death per 100 encounters, we see this in nuclear power plants, in European railroads, scheduled flights. Less than 100, but more than 1,000 encounters, it's by driving, chemical manufacturing, and less than 1 death per 100 encounters is the ones that we can encounter when you do bungee jumping, when you do mountain climbing, and healthcare. So having an airplane have an accident and crash and have people die is a lot more rare than having an ICU death per encounter. That is the equivalent of 10 jumbo jets crashing every week. That's how critical ICU errors are to our healthcare. And that's why it's something that is very important and relevant to attend. So there are several studies that have reported this. There's from all over the world, as I mentioned. There's a Harvard study, 69% of the injuries are caused by errors. In Australia, 50%. There are similar studies in Britain. The Joint Commission has also said that it's prevalent not only to the ICUs, but in the hospitals as a whole, 62%. And that includes the OR. The other thing is that 2/3 of those errors are reported by the institutions. And that means there's 1/3 of them that is not reported. So there's also underreporting to these alarming data. 1/3 of them are by patient complaint or because it's in the media. And almost 3/4 of them resulted in a patient's death. That's the ones that make it to the media that are very notable. This is a review article from the Middle East. Like I said, it's not unique only to the United States. This was a compilation of 50 articles, and they were able to find areas where the errors were occurring. And we will be talking more about the science of errors in the ICU to help you understand how do we come about with these numbers and then how to mitigate these errors in the ICU. So as I said, this is the equivalent of 10 jumbo jets crashing per week. So we can start to find certain similarities between medicine and aviation. And these are that safety should be our primary goal. It's definite in aviation. There's a lot of technological innovation. We saw Dr. Ahmed talk about defibrillators and different techniques and the addition of MRIs, the addition of sonography. How do we come about trying to prevent errors in the ICU? There are multiple sources of threat due to this technological innovation, due to the steps that are required to have a successful either flight or successful patient course. And teamwork is essential. We are well aware of the checklists that pilots have before they take off. Something that maybe we are missing in the field of medicine. So if this is, as we spoke about, if this is very similar, medicine and aviation, why different approaches? Why in healthcare do we assume that you will not make mistakes when human beings are involved in patient care? In aviation, people will make mistakes. So the goal should be to trap and mitigate those errors or those mistakes. In healthcare, we usually assign an individual responsibility. Either the physician is responsible for the surgeon is responsible for the surgery, the anesthesiologist is responsible for the anesthesia, the circulating nurse is responsible. They each have individual responsibilities, whereas in aviation, it's a collective responsibility. And as Dr. Ahmed hinted earlier, it requires a multidisciplinary approach. It requires team approach, but also it requires a systems approach. There is a system to how we provide care, and that is different. It complements, but it's different to providing medicine. And in healthcare, the best is not to make a mistake. In aviation, there is a systemic response of an experience. There's a learned process. And there is also a periodic control of these competencies. Somebody is monitoring quality. And that is something that we, as a healthcare professional or as a healthcare institution, should try to imitate from the aviation industry. So as I said, there are several studies that have analyzed this incidence of adverse events. So this is like an autopsy on medical errors. There's one in Europe, 205 ICUs. There's one in the US. There's another example from Brazil. And there's the Egyptian. I was looking as I was preparing for this lecture, and there's an Egyptian neonatal safety training network. I assume you know about it. It was new to me, and I was browsing through their webpage, and it was very illustrative. So when we talk about the European paper, there were 1913 patients. They were able to identify 584 events. But the impressive thing was that 393 patients had experienced more than one event, and at least 3/4 of the ICUs had experienced one sentinel event. Sentinel event is when there's harm, there's a big potential for harm. So these are not minor mistakes or errors. These are very significant ones. When you try to look at them, the most observed rates of those sentinel events, it related to lines, to medication errors, but also to equipment, airways, and alarms. So you're starting to get a picture that the same way in aviation, this is a very complex environment. It's not only related to the provision of treatment, but it's also related to the system of providing care. Same thing happens in this paper from the United States. It was published in 2005. This was a year-long study event of 2 ICUs, and they were able to identify 391 patients with almost 1,500 ICU days. And the most serious events occurred during the ordering and execution of treatments, especially medications, but not exclusively medications. It was 61% of these patients. And they were able to analyze the types of errors, and mostly were slips and lapses, 53%, rather than knowledge-based. So we know as clinicians what we have to do. So it's usually, right, not a matter of knowledge. It's about slips and lapses, indicating, like I said before, this is a system-based problem. This is in Brazil. They were single patient, 355, and they were able to correlate that these adverse events not only increased mortality, but also increased length of stay. And since we are speaking, I don't know if we have administrators here in our audience, but this is not only pertaining to clinicians, this is also pertaining to hospital administrators and the state as a whole. This is one, like I mentioned, from the Egyptian Neonatal Safety Training Network. This was recently published. This was in 2019. And what was, apart from all the information that they provided, and it's an ongoing, they have updated reports. But apart from that, what struck me the most was that they asked the question, could have the incident been prevented? And the answer was that in 76% of the patients, the answer of the events, the answer was yes. So that is very, very concerning. And that's why when you saw the beginning of this lecture, it's the number 3 cause of death in the United States, errors, healthcare errors. And it's something that is very alarming because it's a preventable event. So based on that, in 2009, this was the European Society. They had the Declaration of Vienna about patient safety in the ICU. And it was to raise awareness of patient safety And to the scientific agenda, we are clinicians based on science and evidence-based medicine. So it's very important that we not only do basic research and clinical research, but also research related to the quality of care that we provide. As you've seen, this errors not only knowledge-based, but are based on other components of the system, and also focus on the teamwork, the collaboration, the communication, and multidisciplinary approach of the critical care team. So with medication errors, one of the things important is to identify the potential, establish solutions, and a team approach to evidence-based. One good thing that it's starting to happen also, this was in April of 2018, there was a survey, and this is the same approach following the Declaration of Vienna to start looking for evidence. And what is the attitude of Egyptian healthcare practitioners? It was not only physicians, they were able to also interview nursing staff and other components of the team as pharmacists and nurses. And they were able to identify 4 areas. One was burnout, the other was workload, the other one was leader-member exchange and what their influence towards advanced events. And what they found was that the leader-member exchange and their attitude, older healthcare workers can play a role in that arena. So it is very important that as senior leaders in the healthcare work, as they are approaching a more prominent leadership role, to focus on these medical errors and how we can attend to them and mitigate them. So let me give you an example on the science of how an error occurs. A nurse gives a drug to a patient. The patient is allergic to the drug, and the patient arrests and dies. Think what would happen in your hospital, what would happen in your institution if you are that nurse, or you're that nurse's supervisor, or you're the chief of that service, or you're the medical director of the hospital, or you're the CEO. What would be your response to this type of event? I can tell you the experience that I've had in the past, and it was not the nurse, probably it was the resident that made a mistake, and the response would be fire that person. That would be your gut feeling when somebody makes a mistake. Have that fire that person or admonish that person. What should be happening is not who made the mistake, but what happened. And there's a theory that's called the Swiss cheese effect, because healthcare systems need redundancy in their system. When you look at an event, you start to do a root cause analysis. So the nurse did give the patient a drug which he was allergic. But if you have a teamwork approach, you could find that probably the pharmacist failed to check the allergy status. If you keep looking, the prescriber, the physician, ordered the medication for which the patient was allergic. And if you keep looking back, the system did not identify that allergy and put it in the chart. So a mistake here, the allergy was not made. When you're prescribing, you should check for an allergy. When that prescription goes to the pharmacy service should also check for an allergy. And when the nurse gives a drug to a patient, there used to be the 5 corrects, now we're like for 11 corrects, did not check for that allergy. So it was not only the nurse's fault, it was the system's fault. So instead of looking who to blame, we should be looking of what happened in the system and how we can correct that so that it does not happen again. And that's things that we should be learning from other industries And I used as an example, the aviation industry. So this is another one when you dissect how an error and what types of errors happen. You have an adverse event, and these are the defenses that we build upon, and we will be talking about those defenses later in our lecture. But there are different types of causes for these errors. And this is like looking at a disease and looking at the differential diagnosis. So you have active failures, and these are slips, lapses, mistakes, violations to certain norms. There are error-producing conditions, and these can be environmental because of the team is incomplete, or there are some failures in the team. Also, tasks. If we are not clear with the tasks assigned to each person, and I can think also in the operating room, I am from the ICU, but also in the operating room, when you begin a surgery, everybody knows their role and tasks are divided, and there's usually a timeout, and these are reviewed, and if there are any concerns. Those are one of the things that have been produced to try to minimize this. There are individual error-producing conditions and device-related. And there are also latent conditions, and these are organizational processes, management decisions that also have an impact on why an error is produced or why an adverse event occurs. So if you hear this, I am proud to say that I don't have any adverse events in my ICU. Well, then that is a very dangerous ICU. And it could be because there's either no documentation of events, there's not a QI process, quality process to evaluate what's happening in the ICU. There are no corrective actions in place, or it could mean that there are no patients in the ICU. So as an intensivist, I usually make lists. So these are my list of common errors that are these in the ICU that could be done in your nearby ICU, and how can we attend to those? So number 10, unplanned extubations and reintubations. And how many times are you rounding and you get called because X and so patient had extubated. In this picture, as you can see, this is where the endotracheal tube is, right? Look what I found. There are several things that could be happening, and usually we get upset because it happened. But if we look at this as a system-based and we dissect this, there are things that could have happened. Either number one, no extubation protocols, and that patient probably was due to be extubated earlier because it was already to be liberated from mechanical ventilation. Was there understaffing? What is your nursing to patient ratio? Do you have a respiratory therapist assigned to your area, and how many respiratory therapists assigned per patient? Was this an equipment failure or a device failure? Usually ventilators, if there's a disconnection, there should be some alarms. There should be some monitoring. There should be people checking on these patients. How does this happen? Number 9, coming from the same point of view, falls and injuries. I don't know if you can notice what's wrong with this picture. And if you notice and look closely, it's a beautiful ICU. It's very ample. It's got a desk for the nurse to be there. Patient is intubated. There's oxygen, there's air, there's monitoring, there's your IV pumps. It's a very highly sophisticated ICU. Look at the bed rails. So those are things that are common and could happen and cause falls and injuries. Was it because the equipment was defective? These are things you need to question yourself. Is it because of understaffing? Monitoring. These are things that you keep in mind when you are trying to assign which cause was for your event. Skin breakdowns and restraints. One of the things when we talk about errors also is you tend also to compensate. So one of the things that we usually see is when you have this, an unplanned extubation, the assumption is that somebody pulled their tube. So then all of a sudden you have number 8, an excess of restraints. And then that causes patient immobilization, and it causes skin breakdown. This is an extreme, right, of a sacral ulcer from immobilization, but we know these happen really fast in an ICU when you have an immobilized patient. Same thing, staffing. I know there are limited resources, and the economy also has an impact. So like I said before, this is not only a medical issue, it's also a system-based issue. Patients with different comorbidities, the type of local care, do you have skin integrity teams that attend to this, or does this all fall solely on the nursing staff? And that will have an impact. Alarms. Alarms, sometimes there's an incorrect setup on your parameters. Understaffing, it's going to be a recurrent issue. There's noise exhaustion. And this is a different type of noise that Dr. Ahmed was talking about when he's talked about noise versus magnet. But when he was mentioning that phrase of noise versus magnet, that was coming to me while I was also thinking about this lecture. The ICU is a very complex environment, the same as the OR. There are a lot of alarms, and there's a high potential for these noise exhaustions or device failure. So what is the usual trigger to do this when an alarm starts going off and it's something that you don't want to pay attention to? You silence it, or you change the parameters. And those things also contribute to a potential error and event. Disconnection of lines and catheters and drains. These could be because of faulty devices, understaffing. There are no set protocols or competencies, as we mentioned before, the monitoring of these devices, the selection. And this one resonates now in this pandemic, because with the shortages of our different materials, what usually an administration does is that they try to get the next available equipment or protection device. So then you get a new thing coming up. Do we train our staff to this new equipment, or do we assume that since it's the same device, in this example, it's a chest drain system, do we assume that that person is going to transition to that other type of device without needing a type of a training? And as you can see here, these are drainage, a chest drain system has 3 things: a drainage chamber, a suction control, and a water seal. But if you look at these 2, they're in different places. So that also creates a potential. This one, there's like 1, 2, 3, and this one is 1, 2, 3. And that new thing, even though it's a minor detail, can cause a significant error and damage and potential damage to a patient. Infections. Infections in the ICU are very commonplace, and that is a problem for patient safety. We have our 3 commons, right? UTIs, ventilator-associated pneumonias, catheter-related bloodstream infections, and the emergence of multi-drug resistant bacteria. Hand hygiene, and as we've mentioned earlier, this pandemic has demonstrated something that's very basic: hand hygiene. So number 4, medications errors. And when we think about errors in the ICU, the most common thing that we think about is medication errors. And ever since there was medical documentation, there's always a potential for an error in the handwriting, but that's not the only thing. Prescription errors, they account for almost half, and it has to be with dosing, but also it has to be with legibility. If you look at this order of insulin, Lantus, what do you read? Is it 80 units? Or is it 8 units? Makes a big difference, right? Well, this was a potential error because it was misread as 80 units. What are the drug interactions? There's an abundance of new medications. There's an abundance of drugs, and interactions do happen. As the example with the Swiss cheese, adverse reactions and allergies, but there's also preparation of medications. And another one, omission. We assume that a medication error might be something that has been administered, but there's also medication errors because we omitted that dose. And how do we go about mitigating those problems? One of my favorites is number 3, the diagnosis. There's this book by Jerome Groupman and How Doctors Think. And for me, when I looked at that is, how can somebody know how I think? I took it personally. But it's a well-written book, and it's more about how communication affects the way we process the input. And it also relies not only on the communication between clinical practitioners, but also the role of patients when they are communicating or when we are doing our history and physical exam with them. So we could have incorrect admission diagnosis because there's also fatigue, or in times when you also have a predisposition, somebody that comes with the same diagnosis of chronic liver disease, encephalopathic, comes again, and it's somebody that frequently comes, but maybe at that one point, it's not encephalopathy secondary to chronic liver disease. It might be a stroke. Failure to recognize comorbidities, and then implementing the incorrect treatment protocol. So going about the number 2, communication, and I think we all agree that communication is key when you're having a complex system and you are very dependent on the team. Hands-off communication, and there are protocols that have been set for that. When there is an incomplete assessment and you communicate that falsely, like the example I experienced with the video that I showed, somebody read stroke and assumed that it was an ischemic stroke, and that was the communication that I received. Gaps of information. When you transition care from different levels and different areas, there might be gaps of information. And number 1 in my list is the underestimation that it could happen to you or that it can occur in your ICU in an absence of patient safety culture. So what are these solutions? Let's have this second half of our lecture in a more positive and uplifting tone. And how can we achieve? And as I said, this is in the ICU, but I think it applies to anywhere in the healthcare system and in a hospital. So as we know, an ICU team is multidisciplinary, and there's the intensivist and the nurse. There's also other people that are involved as respiratory therapy, social worker, nutritionist. Anybody that works in the ICU is part of that ICU team. Even now in COVID, excuse me? No. Even now in COVID times, the role of the people that take care of maintaining the ICU and cleaning the ICU has taken a prominent role. So this one is a study, and they separated the different types of variables. There were 95 variables that could be affecting the quality of care in the ICU. And they divided that in 7 dimensions. And one was human resources, architecture, safety and environment, management of documentation, patient care, risk management of infections, and evaluation and surveillance. And if you can see, and as we mentioned before, these variables apply not only if you are a supervisor or an ICU director, but it also applies to the hospital system, starting with the CEO and going down. And this is something you can also apply on a larger scale, implementing healthcare within a state, a country. Within the human resource, we talk about the staffing, architecture, how is the unit constructed, the way every item that goes into the room, the form of the ICU, how does that relate? If there are barriers to people observing, if you are going to install cameras, if you're going to install monitoring units. Safety and environment, how do you manage your documentation? Are you using paper? As we spoke about, ever since 1800s BC, when it was first documented, how do we keep on documenting and managing that documentation? Patient care, we mentioned about the emergence of multi-drug resistant bacteria and our 3 common infections in the ICU: ventilator-associated pneumonia, urinary catheters, and catheter-related bloodstream infections. There are 3 things that are very common and are caused by devices that we insert into our patients, and a process of QI. Going back to the Egyptian Neonatal Safety Training Network, they did something about the same, and they divided the causes of errors that were associated to the patient, and these are the ones that are listed, being more common, a resuscitation problem. But they also divided it, and this is what I want you to focus about when you're dissecting errors and you're looking at them, and as I said before, like a differential diagnosis, they're also errors related to equipment, they're related to medication, and if they were a sentinel event. So this is a very good approach to dissecting medical errors. How can we start reducing them? Prescription errors, we can use barcoding, computerized physician order entry system, or having a clinical decision, or all of the above. Knowing that every time you bring in something new, that in turn will create other potentials of error. So when you're reducing and you're doing this analysis, when you implement something to reduce error, you also need to think about the risk that this new technology has within. One of the things with the medical error and the computerized medical error, that we thought it was going to reduce risk because of the legibility of the handwriting, was that there was a feature called copy paste. So now we are encountering problems with the copy paste feature. And it's not the problem of the computer, and it's not the problem of the program, it's a human problem when you start doing copy paste. So that's an example of how do you need to anticipate other potential errors. Clinical decision support system, this is more the interdisciplinary team. We'll be talking about the role of the clinical pharmacist and the importance of that role within the ICU. The rate of preventable adverse drug events can be decreased by 66% if you add a pharmacist to your ICU team. And that is not solely their role. They round as a full member of the team, and that will decrease that. One of the things that was found, this is recent, it was published in 2018, this was done in Egypt, was patients with renal insufficiency. One of the errors that was found, it was the majority of them, 2/3 of those patients had a lack of dose adjustment. So by implementing a pharmacist, this can be reduced significantly. When we're talking about staffing. And as you saw, most of the ERs had understaffing in their analysis. These are recommendations. You should have, when you have level of care 3, which is the highest level of care at the critically ill patients, a nursing staffing ratio is recommended of 1:1. Nurse to patient, nurse to bed, 6 beds, and doctor to bed, 5. When you have somebody that is more stable, you can have a 1 to 1.6. That's why we usually talk about 1 to 2. When they're stable, you can talk about 1 to 3. But if you have a very acute care unit and you have understaffing problems, when you should have a 1-to-1 ratio and you start having 1 to 2, 1 to 3, you already know that there's potential to have errors in your unit. And what are you going to do to mitigate? One of the things that you can apply, and it has been demonstrated in this pandemic, that you might change your staffing model. You might have an ICU nurse when you have a scarcity of your staff, but then you can add other types of healthcares, either physician assistants or nurses from other units that are assist, and then you redistribute your responsibilities. Intensivist workload. This is another study that was published in 2005, analyzing the workload, trying to fix what is the ICU intensivist to ICU bed. Usually it's spoken that it's 1 to 8. So they analyzed, and when they looked at these models, 1 to 7, 1 to 9.5, 1 to 12, 1 to 15, they saw that there was no difference in mortality. But when you went up to 115, in level of stay increased from 9 days to 12 days. And then that falls into another type of problem because then you don't have enough ICU beds to rotate in and out. So that's one of the things. Usually when they ask about staffing in the ICU, we try to leer away from 1 to 15 and try to go from 1 to 12 to less. This is another one that's very important when you're starting to strain your staffing ratios. As we spoke about, instead of 1 to 1, you start going to 1 to 2, 1 to 3. The ratio between patients and ICU physician, then you start increasing burnout among healthcare workers. This was a study that was done in 2010. This was an Egyptian experience in the ICU, I'm sorry. And one of the very important things that they found, and these was all healthcare workers, nurses had higher scores than physicians of burnouts. And one of the things that were identified was being a resident, feeling unappreciated, and sleep deprivation. So going back to the similarity with the aviation industry, we know that pilots are assigned a specific flight time. They cannot fly over X amounts of hours, and they have to stay and they have to sleep. So why aren't we doing that to our physicians, to our healthcare workers, if there is the potential of harm? Teamwork approach. This is very important. These have been, teamwork have been implied with reducing adverse events, nosocomial infections, improving quality and reducing costs. It also helps with the flow of bed availability. The creation of bundles is very important when you implement strategies. And that also changes the culture within your ICU team, thinking that even though the physicians are seen as the leader in the team, there are times when somebody else from the team who's not a physician can be the leader for that assigned task. And that also demonstrates that we appreciate them, that we see them as equals in our team. So to give you an example of that, this was Team Boricua. Boricua, that's Puerto Rico, an island flag. And usually if you're from Puerto Rico, you're called Boricua because you came from the island of Boriquen, which was the the name that Taino Indians gave to the island. So if you look at this, at Team Boricua, this was to implement the ICU liberation strategy along with the SECM. You can see I'm here, but the leader of the team was this one, Dr. Enilis Herrera. She was our clinical pharmacist. We had a physician champion, we had medical students, and we also had our 3 nursing supervisors involved in our project. Our goal was to implement the ICU liberation bundles, and we were able to track our performance and implement different strategies. And one of the reasons why the pharmacist was elected as the team leader was, if you can see from the beginning, we were doing very well in assess and preventing pain. Mobility was not that good, but we improved it. Family was done. But our worst scoring was in the choice of analgesia and management of delirium, where pharmacy plays a critical role. So it was very intuitive and easy to deduce that we needed a pharmacist as the team leader. This was published in Critical Care Medicine as a whole, and the implementation of the bundle showed significant improvement, not only in outcomes in terms of mortality, but also in the use of ventilation, coma, delirium, restraint-free care, ICU admissions. So continuity of care, we assume that hospitals don't work 24/7, 365, and it might be our personal perceptions. But there are several studies. It's sort of old and nothing new has been published that I'm aware of in terms of reviewing this. But if you have a complete staffing, weekend admissions are not associated with an increase in mortality, as long as the staffing is maintained. If you don't maintain your staffing, then that's when you're going to have poor patient outcomes. So trying to conclude, one of the other things is that we are scientists. So the approach that we give to care should be evidence-based prevention approach. It should not be eminence-based or convenience-based. And sometimes as leaders, we feel pressures to try to deviate from our evidence. So we do know that appropriate intervention of DVT or venous thromboembolism prophylaxis reduces mortality. So that should be part of our protocols. Use of perioperations in appropriate patients. Sterile barriers when we're inserting catheters, especially central venous catheters. Use of appropriate antibiotic prophylaxis. This is something that is very important. Asking the patients to recall and restate. As we spoke earlier, communication is key, and not also communication between healthcare providers, but also between the patient and the healthcare provider. Pressure relieving materials, and our colleagues in the OR know this for sure, and they're experts in doing that. Using sonography and the advantages that sonography has given us. There are other areas, patient self-management of warfaring, appropriate nutrition, and some that are debatable, like subglottic secretions and antibiotic impregnated catheters have been demonstrated in some studies as reducing complications. One of my favorite books is by Atul Gawande, and it's the checklist Manifesto. And this is also something that has been brought from the aviation industry. If you have checklists and not all items in check, you don't proceed. And that is a way of ensuring quality of care. It's a good way to standardize the care, not only in the ICU, in the OR. If you have a timeout or a checklist before going to the OR, is there an informed consent? Is there a type and cross and there's X amount of blood products available? Did the antibiotic prophylaxis was administered? Did the DVT prophylaxis was administered? All these things that you consider very important and that might affect patient care. If there's a failure of that, you should have them on a checklist. And when everything is checked, then you can proceed. In the aviation industry, until all those issues are not checked, the airplane cannot fly. You don't get a go. These helps also reduce medication errors with a computerized order entry system and a clinical decision support system. An example of this is if you're prescribing a medication, and as we spoke about, 2/3 of one of the papers I discussed was adjustment. You can put a program into that computerized system to cross-reference the creatinine clearance, and that will give you an alert. Prevention of nosocomial infections. You can also program these things to check. When we do our check rounds every day, one of the things that we do at the end is, are there any lines, catheters, medications that can be discontinued? So every day we think, and the rationale for this is, if one of our biggest infections are caused by catheters, then every day we think, which catheter can we remove? And therefore reduce the risk. So my wish for you, and my assignment for you today, to ponder, to think that not only if you can transform your ICU, can you transform your OR? Can you transform your hospital from safety, where it's considered a universal value, to safety, where it's considered a social value, to where a human error is a cause for concern, a cause for dismissal, to a place where human error is a symptom of a disease process that we need to analyze, look for a differential diagnosis, and then implement a treatment plan. Where accidents are caused by individuals, who to blame? To accidents caused by flaws in the system. What happened and what can I fix? To an accident investigation. Accidents are things that happen unexpectedly. Incidents are things that could have been prevented. So if you can change your attitude from an accident investigation to an incident investigation, you find the solution to a problem and mitigate for the next phase. From a culture of blame and punishment to a QI process where you monitor events and try to prevent a sentinel event. So how can we achieve this? And your points to remember as we conclude our lecture: have a strategic planning meeting in your unit. What are your goals? What are your mission and values of that unit? They could be the same as the institution you're working at, but they can be different. They can be variations that are specific to you. Are these goals immediate, midterm, or long-term goals? So when you meet periodically, you can say you meet every 3 months, every 6 months, yearly. You ask yourself, did you reach your goal? What are the newer ones? Did we achieve them? And as you do that analysis, you ask yourselves, what are your strengths? What are your weaknesses? What are your opportunities? And what are your threats? And the last question should be are we getting there? Also remember to celebrate your success and communicate your success with your staff, because they're part of the team and they should know. Ask yourselves, does your staff know your ICU mortality? Do they know your ICU morbidity? Do they know they're doing things the right way or the wrong way and they need to improve? Do they know that? Because they're part of the team and they should be included and appreciated. So with these thoughts, I say goodbye and thank you. Thank you, Dr. Taha, Dr. Ahmed, for that wonderful lecture that you gave.
Thank you.
Thank you, Dr. Saad and Mega, for inviting me to share this moment with you.
Can I just have a question?
Of course.
Okay, well, listen, thank you so much for very, very wonderful scholar presentation, very precise as well. But could you kindly give your evaluation of healthcare professionals' reaction to COVID-19 pandemics and what sort of errors that accumulated over the year and a bit?
Okay, that is a tough question.
It is. You can choose. You can choose any topic. Yeah.
I know. I mean, it's so broad, but trying to put it on a system, right? One of the things, and I did not give this in my disclosure, but I'm a Girl Scout. And I, this is Girl Scout USA, the way it's called in the rest of the world. How do you call them? Girl Guides, right?
Okay.
And our motto is to be prepared.
Okay.
Okay, so when you're doing your analysis, and we're saying this is at least in our country, and we came from a hurricane, a Category 5 hurricane in 2018. We came from earthquakes in 2019. And one of the things the government is saying is we were caught by surprise. We didn't expect this to happen. Well, you know what? I'm sorry?
It was expected.
Well, it had to happen in 100 years. So that's why
I meant it was expected that it will happen. And
of course.
When we had SARS-1, I was in Canada at the time.
Yep.
And we all knew it is coming back to haunt us. And it's not only the government. I was actually regarding even the healthcare professionals. Even who are, okay, go ahead.
I will tell you that's so if you are prepared, you should have known this was coming at some point. Maybe I couldn't pinpoint that it was going to be in 2020, but we haven't had a pandemic, global pandemic. 1918 was influenza pandemic. We had H1N1 in Canada. These type of pandemics. So it's something that when you saw this coming and it was starting to move in 2020, you should have implemented your preparedness protocols. So when you do that, and one of the things that after Hurricane Maria in 2018, one of the things that we did in our hospital is I had a preparedness protocol that it could apply to any type of disaster. So I immediately took that out, and it gives you what do you need to check? What are the, for a pandemic, for an infectious disease disaster, these are the requirements that you need. Who do you need to talk to at a unit level? Do you need to talk to administrators? You had to advise your administrators. We're going to need PPE. We're going to need isolation. We're going to need to change the structure. We're going to need monitoring. So when you do that, then it doesn't catch you as a surprise. So maybe I wouldn't say it was the process of the system, whereas you have medical people advising, and you don't, if the administrators took that advice and implemented that advice. So if you're looking at it, there's not one person to blame or to assign that, how did we fail or not. But I think that if I were to put it in one word, is preparedness. How did we prepare for this pandemic on a global level? And the fact that they have, usually a disease has a timeline. And this pandemic has a timeline, and there's some things that you might predict. The acute part in 2020, when this was unknown, we only had PPE for protection, whereas now we know more about this disease. We have vaccination. So your strategies are probably different. And looking forward, how are you going to do that? I don't know if I answered your question, Dr. Ahmed.
Yeah, I mean, you answered it, the political or the geopolitical aspect of it. But I didn't mean that, because that's actually not in our reach and even beyond the reach of our lecture. I was talking about the healthcare, how, for example, hydroxychloroquine issue and how it was managed. How, for example, the Lancet produced a paper and then withdrew it because there was some flaws in the paper. And the Lancet is a big journal. How even the what you call it, the vaccines, until now, certain vaccines, we didn't have the full workout for these vaccines. I know they were in a rush to produce the vaccines. However, I think we compromised a lot as healthcare professionals. I'm not sure. I just wanted to know your take on that, because it looks like you are in the driving seat for a big ICU, and then you are talking about administration and safety. But I'm talking even, I forget about the governments, because there are many political factors actually are going to play or interplay into that. But I'm talking about our healthcare professionals themselves.
Well, one of the things is we practice evidence-based medicine. So in the phase of an unknown, what do you do when you're, you can take it in the individual aspect. You are in front of your patient and your patient is dying and you have nothing else to do. So you apply knowledge. There's a pathophysiology and you apply knowledge, and you might consider, I'm going to use this because it's been proven somewhere else. But I think one of the problems with what you mentioned, the hydroxychloroquine, the ivermectin in Latin America, I don't know if in your region you're using ivermectin, is that social media has played a role. And, we are all probably in a WhatsApp group, and the information comes so fast that it doesn't go through the filter of, is this evidence-based medicine? And it probably turned into colleague-based medicine. Well, they're doing that over there, but let's use this here. And the one thing that demonstrated the technology is that information can travel quickly, and studies can be done really quickly when we are when we want to do it. I mean, with the amount of information, getting a vaccine rolled out. But as it was said, the technology it wasn't that somebody started with the technology, and in 6 months we have a vaccine. The technology was there. It was just a reapplication of the technology. So science was involved. So that's one of the things. The ivermectin, if you read the data that was used to propose ivermectin, the dose was different. The amount of the dose that it was supposed to be used was toxic to the body. So, those are the things that we as clinicians should never forget, that we should, practice evidence-based medicine. And in the face of desperation, first do no harm. And you need your team and your colleagues also. Maybe intensivists were using something, but then you had it, ID physicians saying the contrary, saying, no, the data that we have does not apply that. I know I gave you another political answer.
Thank you so much. It was wonderful, really wonderful. Yeah.
Thank you.
Thank you very much, Dr. Gloria, for this very nice session, and for linking the medicine with aviation. I really like this. And you mentioned the mistakes, and I really like the first one, the one that's you don't expect that this mistake will happen to you. It's very important, actually. And finally, as you said, evidence-based medicine will actually protect us against any mistakes if we really practice it. Thank you very much.
You're welcome.
Thank you very much. Thank you.
Okay, is the session over now, or any question, or?
Dr. Saad?
I think we are very successful today, like every day. 2 eminent speakers and 1 outstanding moderator. That's as Dr. Gloria said in the beginning. That's one of the advantages of the COVID. We are here honored by the presence of Professor Nabil Asqalani. He is the president of Egyptian Society of Anesthesiologists, and I will leave the talk to him to close this session. Thank you.
Well, as a matter of fact, I'm honored and delighted to attend such eminent speakers. Both speakers are very eminent. Their presentations were outstanding. And my cordial thanks to Professor Saad Al-Mahdi for allowing us to hear from such eminent speakers. That's the first point of view. But concerning the intensive care, I was just demanding, would you prefer the intensive care to be general, or each specialty would have its intensive care? For instance, neuro intensive care, medicine and surgery, coronary intensive care, or cardiac intensive care, or it should be a general intensive care? Which of which? And apart from this, would you prefer separate rooms or multi-bedrooms intensive care?
Well, as the amount of technology, if we're going to apply the same analogy between medicine and aviation, would you have a jet, a fighter jet flown by somebody who flies a Cessna, or do you want a jet driver pilot? A fighter jet pilot driving that one or flying that one. So as medicine becomes more complex and the information, the need for specialized units arises. And I run a neurosurgical ICU, so I might be a little bit biased with your question. And I used to run a cardiothoracic ICU. So the problem with that is that you cannot limit yourself because there's a scarcity of intensivists. And I don't know if the same thing happens in the anesthesia world. You would love to have a cardiac anesthesiology running your cardiac, your cardiothoracic OR. But since there's a scarcity of that, then what do? You need to also make sure that general intensivists, if we can call them like that, are also trained and have the basic knowledge in case there is a lack of of a specialized intensivist to be able to run that type of patient. Not all the places in the world, not all the units can be run by a specialized person. So we need to make sure, it is our responsibility to make sure that everybody has the knowledge. Just in that case, that fighter pilot jet, there's only somebody who's been flying a Cessna. That's why checklists are important. That's why a system-based approach is important, because that way you ensure patient safety in those types of emergency. Your second question was, should we have isolated rooms or a unit full of rooms? This has also been published. The fact, especially with as an infection control factor, if you have individual rooms and somebody has a multi-drug resistant bacteria or an infectious process, the fact that they're already isolated, it's helpful. The other thing is, as we are approaching a patient and family-centered care, the care that we give to our patients, it's not physician-centric. The care that we give, it does not have to be, but it's not mandated that it's comfortable to me or convenient to me as the physician providing the care. Patient-centered care, the care that we give should be centered towards that patient and that family who's suffering the disease, that we give them appropriate care. So they need their privacy. We need to attend that issue. They need also to feel that they have a healing environment, and by having open units with a curtain, I think that doesn't reach the goal. I hope I answered your question.
Thanks a lot for that. No, that's quite fine, but you spoke about fighter pilots, and by the way, I am a Major General in the Egyptian Air Forces, so I agree with you absolutely about what you said. But we'd like to say that the relatives of the patient now play a vital role in his taking decision and in the management of the patient. It's not like before. It's forbidden to visit the
Agreed.
patient. No, on the contrary, they stay with him in the intensive care. That's the new trend nowadays.
It's
Thank you very much.
humanized
Yeah,
care. That's why, you know, having it open, then you can't do that. You can't allow that.
Okay, thank you very much. And thanks to Professor Saad Al-Mahdi for his outstanding performance and dedicated services to all of us. Thanks a lot.